Welcome to the Medication Reconciliation, Gain Support, Define Scope, ID Teams, Designing Process conference call. My name is Shani, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Jody Ross. Ms. Ross, you may begin.
Thank you so much, Jen. Welcome. So great to have everyone here for part 2 of our 4-part medication reconciliation series. I will be the presenter today along with Tony Kettner. Tony Kettner is our subject matter expert for medication safety out of Medicine, Wisconsin, and works with a team of experts through our Lake Superior Quality Innovation Network. So it's our pleasure to have participants from Michigan, Minnesota, and Wisconsin today. I hope you all were able to get the slides as they were available as you signed in. The recording will also be available on the LS2IN website through the YouTube site. It will be there in it'll take a couple weeks to be posted there, and then be available for several weeks ongoing. And we'd like to ask everyone to download the Match Toolkit, and there is a link within this presentation. And it is a source from the Agency for Healthcare Research and Quality. And want to continue to thank everyone who submitted their baseline assessment, and we'll be asking for a second assessment before the next webinar as well. So thank you. So without further ado, we will get into the continued education disclosures. So again, thank you for presenting. Because Medistar is providing continuing education credit for this presentation, we need to inform you that no commercial support has been received for this learning activity. The speakers have reported no conflicts of interest, and there are no planner conflicts of interest. For CE credit or certificate of attendance, you must attend the entire session and complete an online evaluation that you will receive. We encourage everyone to complete the evaluation to provide feedback on the session. And again, it's my pleasure to be presenting this with Tony Kettner. And with that, we'll start with our current objectives today, which will really be explaining the benefit of standardizing the medication reconciliation process, to describe how leadership can be engaged around initiatives that support medication reconciliation, to identify the process of building the foundation for a med reconciliation project team, as well as explain how to design or redesign the medication reconciliation process. We'll continue to be expanding on session 1 that was presented at the end of April and is available on the LS2IN website too. And we'll be utilizing the Match Toolkit, and that is available on this link as I had promised. This is a great tool that we'll continue to use as a reference throughout this entire series. One of the pillars for quality is really standardizing a process. So it's a great opportunity for us to talk about how we can standardize the medication reconciliation process. As we reduce variation, we can make sure that we're getting the outcome that we would like. And a great way to start with standardizing the MedRec process is to really start with that shared vision and really agree on what medication reconciliation is. To really define what we're talking about so that we can also all speak the same language. We know that med reconciliation is complex and continuous. We know that it affects all patients across all settings and within the community. We know it is a comparison of medication lists from multiple sources, whether it's a provider or multiple providers with different lists. It's really that list that the person has that is really what they're using. We know that it reduces medication errors as well as adverse drug events. And we know that it improves patient outcomes. That will result in less hospitalizations and rehospitalizations, which can really promote the well-being of the beneficiary. And it can be really helpful to talk about that with your team, make sure that everybody agrees on what medication reconciliation is, how we can standardize that process. We do know that methods vary across settings. They can vary across professionals. We know that med reconciliation is a requirement of many regulatory agencies, as JCO and the Division of Quality Assurance, Human Health and Services. We know that it provides better, safer care, and it is likely tied to a metric that is already being measured in your organization and may also be linked to payment, so it can be a great quality initiative. Medication errors are largely preventable, so it's something that we can really make an impact on by really understanding what is our current state of med reconciliation. An organization can also benefit from standardizing the process by decreasing variations within the process to produce fewer unintended consequences. Really understanding what that process should be and how can we get to that ideal state. Improved ability to identify and correct medication discrepancies and errors within a standard process, which in turn results in improved patient safety, which would save time and money. When we all on a healthcare team, including the beneficiary, knows what we should be taking when and how we should be taking it, it really results in improved communication that gets to those improved outcomes. And it really encourages role definition and accountability, which can be essential for preventing errors. Getting a correct list and really doing that reconciliation really may take more effort up front, but it will prevent a lot of problems and make sure that we're giving the right care at the right time to the right person. So using that team approach is really important. And with that, I would like to turn this over to Jody.
Welcome, everyone, and thank you, Jody. Just a couple of things I wanted to add today. We did post the link to the CE evaluation that we're asking you to complete in the chat box to make it a little bit easier for you. There should also be a slide with the link, but we thought maybe this would also be beneficial. And I just wanted to recap a little bit. The goal of this work all revolves around adverse drug events and helping and hoping to prevent them from occurring across all settings. So the goal is really to prevent harm from occurring and have better outcomes for patients and less hospitalizations and rehospitalizations. And that's the scope of work that the LSQIN is involved in right now in all 3 states around adverse drug events. Hence, this is just one mechanism that we're offering and sharing in order to see if we can have benefit from folks getting involved in this kind of activity and looking to improve the medication reconciliation process. So I just wanted to start out talking about the MATCH Toolkit, which stands for Medications at Transitions and Clinical Handoff. And it's really a roadmap to improving the medication reconciliation process. The little guide that, if you haven't already, you will download includes chapters 1 through 7, and it really breaks the whole process down very nicely into kind of bite-sized pieces that you're easily able to work through. As Jody indicated, it is scientific evidence-based. It was developed through the support not only of the Agency for Healthcare Research and Quality, or AHRQ, but also they did it in collaboration with a couple of well-known organizations, including Northwestern Memorial Hospital, Northwestern University School of Medicine, and of course the Joint Commission. Just a word about that. Even though we generally think of the Joint Commission as being hospital-based, they have multiple accreditations. This tool is really easily available and easily can be used by other organizations as well. Very adaptable to long-term care, home care, and other settings. So the tools and it's actually the Match Toolkit are tools and process resources for acute care, which I just indicated can be very readily adapted to other settings. And it's really an opportunity to take a look at and review and improve your current practices. You know, we're always looking at what's the current state and how and what kind of impact might we have on some future state that actually serves our patients better, is more efficient, is less expensive, and has improved outcomes. And that's all kind of the triple aim. We hear a lot about that. And the Match Toolkit really provides a foundation for a really strategic implementation of the medication reconciliation process chapter by chapter. So many of you are familiar, if you've worked with Metastar before and or are familiar with the Institute for Healthcare Improvement, the Plan, Do, Study, Act, or PDSA cycle. The Match Toolkit uses a very similar format to Plan, Do, Study, Act, although it just calls it different things. So instead of 4 sort of series in a process, they're talking about defining, measuring, analyzing, improving, and then controlling, making sure that whatever processes you put into place are maintained. So very, very similar kinds of focus that both Plan, Do, Study, Act, and the Match Toolkit are using. So that's another reason why it makes it easy for people to, to be able to use the tool. So we're going to start out talking about building the project foundation, gaining leadership support within the organization. So I think it would be rare to find leaders in any setting that would not agree that patient safety and medications are extremely important and really go hand in hand. We all know that there are vulnerabilities that exist for patients during transitions of care. And there's been a lot of research done and a lot of work out there. If you look in the literature, you don't have to look very hard or far to find that transitions are a particularly tenuous time for medication issues to arise in terms of adverse drug events, medication errors, all kinds of potential areas for vulnerability. There are also findings that continue to demonstrate significant discrepancies between what medications the patient is taking versus what's actually been prescribed that also lead to adverse outcomes. And I think we can probably all think back to a time when during a transitional process, we had this very same thing happen where something was prescribed that either the patient was taking it or they were taking something that hadn't been prescribed that they had had at home and just thought that they should continue. There are also many financial incentives that exist for building and maintaining a sound medication reconciliation process. We are moving further and further in terms of pay for performance, where payers are looking for who can do the best job and do it the most inexpensively and have the best outcomes. And if you're in an area that's also affiliated with accountable care organizations, they're also looking to partner with those people that can do the very same thing. Because again, and it's unfortunate to say, but payment is certainly huge and continues to be, and I don't see that changing at all. Also, I think in terms of patient safety, this whole Match Toolkit, we want you to be able to link it to other kinds of initiatives that you're already working on. And there are things, for example, if you're in a physician office with the new payment structure that they have, and in nursing homes with some of the new payment structures that they're encountering, because everybody's looking to decrease hospitalizations and improve safety. So our intention here is not to make extra work, but to have you look at how can you tag on to work that's already being done in your organization. So it's a win-win for both you and your patients. So medication reconciliation links directly with other initiatives. Jody had mentioned the Joint Commission. The Centers for Medicare and Medicaid were all required, or most of us are doing satisfaction surveys. We've got star ratings for pharmacies, so there's a whole host of initiatives out there that directly relate and link to patient safety and can also link to medication reconciliation. In terms of convincing leadership in support of this endeavor, everyone, as I indicated earlier, is looking at trying to decrease hospitalizations and rehospitalizations. We're all being measured and looked at in terms of what kinds of hospitalizations rates we have as compared with others that are in similar organizations as ours. And so it really behooves us all to be working together and attempting to, within the community, we have vested interest, all of us, in decreasing hospitalizations. And then I had mentioned the triple aim, which is improving population health, improving the patient experience, and providing more cost-effective care. Is the cost worth it? If you look at the Match Toolkit, there's a study that's referenced there that indicates that 36%, 1/3 of all patients had errors in their admission orders. And that's really mind-boggling when you think about that. 1/3 of all patients on admission, and that's basically was looking at hospital admissions, but we know we all know, we know this anecdotally, we know it if we have data, that not only includes inpatient settings, but also there's a large percentage of errors that occur in nursing homes on admission, in home health to admission, in all kinds of other facilities on admission. Inpatient preventable medication errors cost approximately $16.4 billion annually. And the key word there is preventable. There are a lot of things that we cannot control or prevent, but this is one of them that we can. We can certainly have a huge impact on, and we can make a conscientious effort to really prevent medication errors from occurring. Outpatient preventable medication error costs are approximately $4.2 billion annually. So again, a huge amount of money being spent on the cost once medication errors having and not to mention the pain and the suffering that the patient might experience and go through. And there are some models that are used to calculate potential gross savings of improved medication reconciliation processes in your Match Toolkit on pages 4 and 5. And it's really kind of cool because one of those was developed by an individual, a pharmacist in Minnesota, and one was developed by a pharmacist in Wisconsin. So that's pretty cool that within our LSQIN, there's been a lot of work done and people paying attention to this in our 3 states.
So thank you, Tony. And this is Jody, and this can be great data to use as a value proposition to take the leadership to really make sure that they can allocate time and resources for your team to make medication reconciliation a quality improvement priority. Thank you, Tony.
Thank you, Jody. So let's move on to taking a look at building the project and looking at project teams and the scope of your project. So what we're going to want to do initially is to identify and assemble our interdisciplinary team, and keyword interdisciplinary. And it's very important, no matter what your setting, to be sure that you have a pharmacist included in your team. And if you're an outpatient organization, say like maybe a home health agency, you might want more than one. And maybe you want somebody from a hospital if you're a hospital-based home health agency. Maybe you want a couple from the community, depending upon what your setting is. But they play a very integral part in medication reconciliation and will be very, very helpful. Not to mention all of the others, but it's very important to identify who the individuals on the interdisciplinary team that you feel that you need to have. it's important to create a flow chart of your current medication reconciliation process, and then to develop a project charter or a work plan to help you kind of navigate your way through this, and then to establish some kind of measurement strategy. So we're going to take a look at each of these items individually. So first of all, the interdisciplinary team. You need to put some thought into this and really try to identify who are those key stakeholders. I've been involved in multiple projects, and it's very important, as I said, because you don't want to leave someone out or forget someone that has a piece to it. So it's very important to include, folks who actually are doing the work because they actually know the process better. But you might also want to have someone from leadership, maybe somebody from process improvement, depending upon how large your organization is. As I mentioned before, a pharmacist, and there can be a whole host of other people. It also makes a difference kind of what your focus is going to be, if you're doing something within a certain department or if you're outside of and working among and between departments, to be sure that you're also identifying individuals, within the scope of your project. Communication and reporting are very important. You want to make sure that everyone is kept in the loop. And so that includes not only the individuals who are going to be part of the team or make up this medication reconciliation interdisciplinary team, but also how are you going to communicate and provide reporting to others that may need to know, for example, your leaders and or other individuals who are maybe just in the field, and they need to all be kept in the loop. So good reporting, good communication. What kind of support does this team need? Do they need support from leadership? Do they need support from IT? Do they need support, if you're a large enough organization, from your performance improvement department? Is it something from finance? So really look at who are those individuals that can help provide support to you so that you will have a really successful team. And then it's also important to identify the roles and responsibilities of each of those team members so that people are really clear about that. If you look in the Match Toolkit, it actually looks at dividing the team into 3 groups. And again, depending upon the size of your organization, that might be realistic. In others, it might not. And they refer to a leadership team, the project sponsor, design team, and then the design team, which is actually the on the boots, on the ground kind of people. But again, depending upon the size of your organization, you may not have that structure. You may just have one team. Okay, so it's important to gather the team and to flow chart the current medication reconciliation process. And I can't say that enough with an emphasis on the current process. And this process then, that once you've gotten this down or it's visual to all, can help you develop a charter or a work plan and also determine what's going to be measured. Okay, so there's a nice discussion in pages 15 and 16 of the Match Toolkit. So flow charting your current process really puts everybody on the same page and identifies not only what areas you might want to improve on, but the areas that you're really successful at. And that's important because if something is working, why change it? It also identifies inefficiencies and gaps in the process. It helps to identify current roles and responsibilities and perhaps also look at, how those might need to change as you move forward in the project. It helps you to determine if you're going to need a brand new, totally different process or if the current process just needs some redesign. It also gives you some guidance for the next steps. And just a couple of things I'll say about flow charting. I recently was on a team with a group of people working on handoff communication. And so we had everyone sitting at the table, and we started to flow chart the current process. And it was funny. It was also, it did my heart good because immediately people started to see where all the inefficiencies and the gaps are. So we had to, keep sort of saying, no, this is the current process. We need to get all of it all down so we're all on the same page. And that, I think, is just human nature, and especially maybe in healthcare, we see something and we want to fix it immediately. So just a word of caution. It's wonderful to see that, and people who are very enthusiastic will want to do that, but try to just get them to understand that you need to be able to get the current process down first, and then you can move on to where the areas are that you need to work on. And also, depending upon where you're at and how large your organization is and whether this is crossing departments or whatever the case might be, there might be more than one medication reconciliation process that you need to consider. So ask yourself, do we do something different for new admissions? Do we do something different for, hospital when we're discharging people? Do we need to have different processes? If so, maybe take a look into that. But really also making sure that you're really identifying what the scope of your process is. And of course, the smaller your process and the more finite it is, the more success that you're going to have. So this is just a picture, and typically I have done things like this, sticky notes, colored sticky notes. And again, this is just one way to do a process map or a flow chart, your current process. Once this is done and you've got all the steps outlined and you think you've got everything where you need it, you can have someone who's very computer savvy take these sticky notes on a sheet of paper and move it onto a computer in a really nice format with all the, symbols and so forth and so on, and really get it looking pretty, if you will, so that people really can then see it in its entirety. And then it's important, once you have that done, to go back and look again to be sure that you didn't leave anything out or forget something, or somebody has another piece that they need to add to that. So the next part of building the project would be to develop your charter or your work plan. And again, the Match Toolkit has some information about how to do that, really easy to read and understand, in your appendix on pages 7 through 9. And your charter, your work plan, is really your roadmap. It's the who, what, when, why, and how. And it really helps to keep your project focused. And it really helps to get input and feedback from all the team members so that everybody can feel ownership for this. And that's very important because you want people to own this. If they don't own it, there will be a lack of accountability and perhaps a easier failure in terms of what your project is going to look like and what's going to happen at the end. And it also, in some instances, will meet regulatory and accreditation requirements. And I've been in a couple situations, both in hospital setting and in long-term care, actually and in home health, where we were able to take out the project that we had worked on, and they could see it from start to finish, including, our flow diagram, what our charter looked like, who those people were that were on the team, what roles and responsibilities were, and I think that goes a long way toward not only meeting regulatory requirements, but also giving, having people take ownership of it, and also giving credit to the people that were part of this team. It's nice to see your name in print that you were part of a project, and recognition, I think, is also very important. Before I go on with that, I'll just give a little tip that I have. There's a tool in Lean called the paper passing tool that can be really helpful and useful in terms of helping build a charter and kind of defining what it is you're working on. So you're sitting around the table and everybody gets a blank sheet of paper, and you have them write down on the sheet of paper, what they think the issue is. It could be what the issue is, what they think the goal should be of the project. And leave space between any lines that you write in, because what you're going to do is you're going to pass that around to the person on the right, and you're going to receive one from the person on the left, and you underline the key words that the person has written that coincide with what your thoughts and processes are. And you pass that all around the room, and so words may have more than one line under them, and then you sort of take a look at that as a whole group and pull out the words that people, that maybe have 5 or 4 underlines under them, and you kind of go down the list. And it's a really nice way to have a recorder just kind of capture what it is, what people's thoughts are, and really easy and a really nice, pretty convenient way to be able to get a good start on your charter in terms of what the scope of your project and the goal is going to be. So the next part of it is to establish some kind of measurement. So if we want to know that what we're doing is going to work, then we need to figure out what kind of baseline data it is that we need to collect. So it's important to remember to look at what you already have, what data you already have, what already exists, and what data you need. Because again, don't make it any harder than it already is. And collecting baseline data doesn't have to be a huge process. It can be very, very simple kind of auditing that someone is responsible for doing. But again, look at what you already have. Involving an individual from the IT department or somebody who's really familiar with your electronic health record reporting capabilities is probably a good idea. Many of them have multiple reports that can be run, and so it's important to identify somebody, and probably that person should be on your team who's able to help you get that information. And then to decide how you're going to collect the data and who's going to be accountable for it. And it's really important to remember data drives decisions. And this hit home with me at my last place of employment we were working on. It was that same handoff communication tool that we were working on. And we were able to demonstrate that the process that had been currently being done was very time-consuming, and actually, as we did studies then on the back end, that much less time was really saved. And so that went a long way in, showing or demonstrating to the nurses that this process was really a good one, because it would save them time, and we're all interested in saving time.
Thank you, Tony, and that's a great example, and it's always great to include the people with the process. I love the saying, nothing about me without me. If it's going to impact you, you will have more buy-in if they're involved, so it's great to consider the team with that, and the data is so important to drive the work, and that it really can help us show where are the priorities and where can we get the most impact for our efforts, so that is so important. In the flow charting and looking at what is the current state, if you would like assistance with those processes, we are available to help. I appreciate feedback in the chat that the slides are not available, so we did just email those out as well. And it is our next step to go through developing change and designing the med reconciliation process. And already today we've talked about getting leadership support, we've talked about having your charter, gathering your team, flow charting the current state, you're having your work plan, looking at your measurements. So they're all evidence-based pieces of a QI project. We're fortunate to have the Match Toolbox to help us with the charter and the other tools that we need. So it can really help us comprehensively work on getting the medication reconciliation process where we'd like it to be. And please let us know if we can help with that process. As we continue to look at developing change in Chapter 3 of the Toolkit, we'll look at developing those guiding principles, as Tony mentioned, defining those roles and responsibilities, really integrating MedRec into existing workflows. And what's really exciting is then flow charting the new design or the redesign. What would be our ideal state? getting out those stickies, working through that. And for the guiding principle for a successful change, it's really important to have that one source of truth. One medication list that is shared by all disciplines. Really going back to the importance of standardization and keeping it simple, keeping it efficient, and removing any redundancies or barriers. Again, those roles and responsibilities is so important. People are generally hungry to know really what is my role, what am I supposed to do. Often when there's breakdowns in the process, it was because we didn't know who was wearing the sign. And so really keeping everyone involved in that process is so important. And the more that we have that shared vision of the importance of that one source of truth and having that med reconciliation, or that one med-rec list that can be so important, or medication list, And then we continue with our charge by educating staff, educating patients and families, making the right thing to do the easiest thing within the normal practice patterns, removing the old way of doing things, making sure that the process is supported with having it the things that we need available, making sure that there's proper reminders, building those into EHR if we're able or into other systems, focusing on compliance with regulations and accreditation and how we can use the work that you're doing to improve medication reconciliation for compliance as well as quality. When we think about roles and responsibilities, this is a great list of things to consider within your team. Who will create that one source of truth? How will it be validated? Who and how will it be maintained? How will this be communicated? And to whom and when? And are there different steps to take if the patient is new? Tony mentioned this earlier, where are those pieces that may affect your process? What if the patient has just been discharged or went to see a specialist? Might there be more information that we need to gather? And how do we also update the patient, the family, and the caregiver and make sure that they're empowered within their medication regimen and really understand the importance of taking the medications in the way that they're taught to do so? Really integrating the medication reconciliation into existing workflow is crucial. Having those prompts and reminders built in are helpful. We know with working with people within complex systems, it's really important to not just rely on our memory. Having checklists, having built-in reminders is so important. And it needs to occur at the right time, so those reminders can help make sure that it's done at the right time. And it can also improve the likelihood that the process is performed as desired, so it keeps it standardized. The electronic health record can be a great tool for that. You can be working with your vendor to make sure that it prompts a trigger, an action that occurs at specific times in the workflow process. There's also paper-based options, of course, the medication list, having it in a very prominent place, a specific place in the chart, potentially having that also in that electronic and paper form, something that's easy to share with the patients and their family and caregivers. This is one of my favorite parts in quality, flow charting, the new design or the redesign. What is our ideal state in creating that new flow chart that documents the new or revised process that's ready to be integrated into the workflow, that you have your input from the team and you can really display that new workflow, really work towards achieving that standard process, and compare it to that original to highlight where it's saving them time and promoting safety and reducing costs. And Tony's example that she provided earlier is a great example of how it can buy-in and improve satisfaction amongst the team as well. So developing team flow chart. This looks very involved, but it's well defined. It really shows those roles and responsibilities. So it can be so important. If we have concern as we're developing that ideal state, we go back to that charter. But that is so important within the process. So as we are nearing the end of part 2 of this 4-part series, we appreciate the first baseline assessment. The second one could be turned in after this session about mid-June to really reflect what are the changes that you've been able to deploy, especially with chapters 1 through 3 from the start of the series in April till June. The acts of the series are really to define that medication reconciliation, agree on the med reconciliation definition and process, and have leadership buy-in, have your team selected, and really using the toolkit in the chapters 1 to 3 in the next 30 days. I realize that's a lot of extra work, so again, let us know where we can help you, or if that timeline needs to be adjusted within your organization that is understandable. But building that team is so important. So even thinking through at the end of this webinar, what can you do in the 5 minutes as we close before your next task or meeting or patient appointment to make sure that we can be looking at the team, how are we going to do a project plan, when do we want to process maps, so that we can continue to develop those guiding principles, define roles and responsibility, and really focus on the workflows to keep that part of the QI phase really active. And in summary, med reconciliation is an ongoing process. It is an integral part, especially during high-risk times with transitions of care and handoffs. Primary care providers, the hospital, the community pharmacists are all essential in this process, and it can really engage them to update patient medication lists at every encounter and to consider how we share those. Really includes what is that person's needs and their caregivers to make sure that they can be managing chronic and acute illness as well, and that is crucial to have the appropriate medications and to be taking them in the right way. It looks at community partnerships and coalitions to spread the word and gain support and continue to deploy the work. And with that, I'm going to see if you have anything to add, Tony, before we open it up to questions.
Thanks, Jody. I just did want to reiterate again, because this is a 4-part series and we're collecting data across all 3 states, so Wisconsin, Michigan, and Minnesota. And so after today's webinar, you're going to get a CE evaluation that you're going to be asked questions that really pertain to the content of the webinar today. In a couple of weeks, on around the 13th of June, you're going to get a post-webinar assessment and that assessment, we're referring to those 9 questions, just like the ones that you would have answered in the baseline, because what we're wanting to do is to measure you from the initial baseline assessment through these first 2 webinars to see what kind of progress has been made and whether we're able to move the questions that you answered no to yes questions. So do be expecting that. It'll be around the 13th. It'll be an email that looks like it came from me, Tony Kettner. And again, we're really, all 3 states are really asking that people really take the time, to fill that out. So that we're able to use this as a mechanism to not only document improvement and to take credit for what we're all doing, the good work that everyone's doing. The other thing that I would add is that if anyone is wanting some additional help, if you would feel comfortable emailing me, please do that. And then if you're from another state other than Wisconsin, I will connect you with Heather in Minnesota or Gloria in Michigan, and they can help you with if you need like more tools or you need some one-on-one assistance of any kind. So please don't hesitate to contact me, and we're all here to help you and to support you in the good work that you're doing. So I just wanted to add those few things. And with that, are there any questions, any thing that we can help anyone with today?
Thank you. We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone.
If I just might add a couple of things while we're waiting to see if there are any questions. For anyone that's interested, I just read a really good article in the online JAMA. It was dated April 20th of 2017, and it was entitled Beyond Medication Reconciliation, the Correct Medication List. And the author had some really good points, I thought, in terms of providing support or the reasons for medication reconciliation. And just to reiterate, I know we've talked about this, but having the correct medication list will prevent problems that would have taken even more effort to solve. And so I know that we're all busy in our day-to-day activities, but that is a good point that he makes, and one that we, I think, made in the first session, that there's gonna be some time consumed somewhere. Better to do it on the back end than it is to try to do it on the front end, and especially in terms of trying to prevent things from occurring. And the other thing I wanted to mention, somebody on the last session had asked a question about bridging their electronic medical record and patient forms. And I was just wondering if anyone who had experienced that had any words of wisdom for this individual.
And we have no questions at this time.
Okay, thank you. It was interesting. This person, the vendor of their electronic medical record, indicated that medication reconciliation is a physician responsibility only. I was just curious if others had thoughts about that.
Yes, thank you, Tony. Very interesting. I tend to think it's all of our responsibilities, especially when it's patient safety, but
it kind of, that prompted me to think about, in the OR, if there's something's going to happen that anyone can speak out. I guess I agree with you. It's sort of the same principle. If we have really well-defined roles and responsibilities, why can't multiple individuals on a team, and it really is a team approach and needs to be, go in and make additions and corrections to a medication list. To put all of the weight on one person doesn't seem reasonable to me in this day and age, but that's just my thought process. Anybody else care to share theirs? Okay, well, it doesn't look like we have any additional questions coming in, either via chat or on the phone. So again, please feel free to reach out to me, and I will connect you with the task lead. If you happen to be in Michigan or Minnesota, we would all love to help you very much on this project. So with that, I think we'll call it closed, and thank you again very much for joining us. Please make sure that you register for webinar number 3, and if you haven't already, to download the Match Toolkit. Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.